This is Professor Nicholson lecturing on normal physiologic changes in the mother and fetus during pregnancy. Please review Unit 3, Module 1 subcompetencies on your own. Fetal development during pregnancy is measured in the number of weeks after fertilization, which is a duration of 40 weeks or 9 months. This slide presents the stages of fetal development. The first is the zygotic stage, which is the fertilization of sperm and egg, or you can also call that an ovum, through the second week. This is also called conception. Blastocyst stage is when the zygote divides into a solid ball of cells and attaches to the uterus. The embryonic stage is when major structures and organs begin to emerge by the second week through the 8th week. The fetal stage is when those structures are differentiated, and this starts by the 8th week until birth. As you can see, this is why prenatal vitamins are an important supplement during pregnancy. You need to know that the embryonic period of development is the development of basic organ systems. It begins with the fusion of the oocyte, also known as the developing egg, and sperm cell. This eventually differentiates into 3 germ layers. Some cells become the embryo, while others become the membranes that surround and protect it. The ectoderm layer forms the central nervous system, special senses, skin, and glands. The mesoderm layer forms the skeletal, urinary, circulatory, and reproductive organs. And lastly, the endoderm layer forms the respiratory system, liver, pancreas, and digestive system. These are all formed at the same time as the embryonic membranes. All tissues and organ systems develop from these 3 layers. It's amazing how several weeks will pass during this process, even before those quote-unquote presumptive signs of pregnancy, as we will discuss shortly. Your textbook has a great visual of the embryonic and fetal development week by week. This slide is a small amount of what is in your text, and it's reflective to your subcompetencies. However, I will stress you know the following, especially what I'm about to mention. Vernix on the fetus is at 20 weeks gestation, and this is also the time there's an audible heartbeat. During the 3rd trimester, subcutaneous fat is deposited. Also, know that the heart development is complete by week 20. Take a moment and review this slide on your own. The placenta serves as the interface between the mother and the fetus. This slide shows the important functions of the placenta during pregnancy. I highly suggest that you review this slide very carefully. Hormones produced by the placenta. Please know that the human chorionic gonadotropin, which is also known as HCG hormone, stimulates the corpus luteum. A refresher, in case you do not recall what the corpus luteum is, it produces the hormone progesterone that makes your uterus a healthy environment for a developing fetus. A new corpus luteum forms each time you ovulate and breaks down once you no longer need it to make progesterone. The umbilical cord is formed from the amnion, which is a thin, tough membrane that protects the fetus. It is a lifeline from the mother to the growing embryo. It has 1 large vein and 2 small arteries. A way to remember this is a smiley face. The eyes are the arteries, and the mouth is the vein, or in my way, I think of the name Ava. The A's are for the arteries and the V is for the vein. The umbilical cord is surrounded by Wharton jelly, and this prevents compression on the arteries and vein. On average, a term umbilical cord is 22 inches long and 1 inch wide. That's just an average. You do need to know that the umbilical vein carries oxygenated blood from the placenta to the fetus. The umbilical arteries carry deoxygenated blood from the fetal circulation to the placenta. Amniotic fluid surrounds the embryo and increases in volume as pregnancy progresses. It reaches approximately 1 liter at term. It is derived from fluid transported from the maternal blood across the amnion and fetal urine. Its volume changes as the fetus swallows and voids. It is composed of 98% water and 2% organic matter. Adequate volume is necessary for proper fetal growth and development. You may hear the term oligohydramnios, which means too little amniotic fluid, or polyhydramnios, which means too much amniotic fluid as you observe labor units. I will not go in depth with these, however, you will find these come with potential complications. I will not read this slide in its entirety. However, I highly suggest you review this very carefully as you need to know these major roles of the amniotic fluid. I have discussed fetal circulation in a previous lecture this semester, so please review this. This is the blood flow from the placenta to and through the fetus and then back to the placenta. There are 3 shunts during fetal life. The ductus venosus, which connects the umbilical vein to the inferior vena cava. This bypasses the liver. The ductus arteriosus, which connects the main pulmonary artery to the aorta. This bypasses the lungs. And the foramen ovale, which is an anatomic opening between the right and left atrium. This bypasses the right ventricle. There is a great file within this module tab that has images to help with your review. The 11.4 table in your Ritchie text is a great source to study these physiologic and anatomic changes in the expectant mother. Regarding the endocrine system, this controls the integrity and duration of gestation by maintaining the corpus luteum. A lot of hormones are involved with this process. Regarding the uterus, it increases in strength and elasticity to allow the uterus to contract and expel the fetus during birth. Regarding the breasts, an increase in size and areolar pigmentation occurs. Regarding the cardiovascular system, this occurs early during pregnancy to meet the demands of the enlarging uterus and the placenta for more blood and more oxygen. An increase in blood volume occurs by approximately 1,500 milliliters, or up to 50% above non-pregnant levels. This supports the placenta and arteriovenous shunt in the maternal vascular compartment. You need to know the physiologic cause of varicosities in the lower extremities and vulva is due to the compression of the abdominal veins by the progressively enlarged uterus. Regarding the respiratory system, the amount of space available to house the lungs decreases as the uterus puts pressure on the diaphragm. This causes a pregnant woman to breathe faster and more deeply because she and the fetus need more oxygen. Moving on to the GI system, smooth muscle relaxation and decreased peristalsis occurs related to the the influence of elevated progesterone levels. This results in delayed gastric emptying and decreased peristalsis. Regarding the urinary system, hormonal changes increase blood flow to the kidneys. The biggest structural change in the renal system during pregnancy is dilation of the renal pelvis and the uterus. Regarding the integumentary system, most women experience hyperpigmentation during early pregnancy due to hormone fluctuations, typically generalized and mild. Many pregnant women express concern about stretch marks, also called striae, as well as skin color changes and possible hair loss. Many women experience the pigmentation that extends from the umbilicus to the pubic area. This is called the linea nigra, and I have a picture of that right here on this slide. Lastly, the musculoskeletal system. Postural changes occur during pregnancy. The woman has an increased sway back due to the enlarging uterus. The loosening of the sacroiliac joints could cause lower back pain. The hormones progesterone and relaxin have an influence on the pelvic joints as it supports the growing fetus. There is also an increase in the lumbosacral curve, leading to a waddling gait. Presumptive signs of pregnancy are those signs that the mother can perceive. The most obvious is the absence of menstruation. Skipping a period is not a reliable sign of pregnancy by itself, but if it is accompanied by consistent nausea, fatigue, breast tenderness, and urinary frequency, pregnancy may be likely. Presumptive changes are the least reliable indicators of pregnancy because any one of them can be caused by conditions other than pregnancy, such as amenorrhea, GI disorders, cancer, oral contraceptives, etc. Probable signs of pregnancy are those that can be detected on physical examination by a healthcare provider. Ballottement is when the examiner pushes against the woman's cervix during a pelvic examination and feels a rebound from the floating fetus. This is around 16 to 28 weeks. The Goodell sign is softening of the cervix, which is around 5 weeks. The Heger sign is softening of the lower uterine segment or the isthmus, around 6 to 12 weeks. And the Chadwick sign is a bluish-purple coloration of the vaginal mucosa and cervix, which occurs during weeks 6 through 8. Positive signs of pregnancy. This is usually within 2 weeks after a missed menses. Enough subjective symptoms are present so that a woman can reasonably be sure that she is pregnant. However, an experienced healthcare provider is the one who can confirm it. Positive signs of pregnancy confirm that a fetus is growing in the uterus. Visualizing the fetus by ultrasound, palpating for fetal movements, and hearing a heartbeat are all signs that make a pregnancy certain. If the pregnancy test is positive, a visit should be established so that the estimated gestational age can be determined. Patients should receive information, such as normal signs and symptoms of early pregnancy, and be instructed on when to call regarding concerns. Once pregnancy has been confirmed, the healthcare provider will set up a schedule of prenatal visits to assess the woman and her fetus throughout the entire pregnancy. Assessment and education begins at the first visit and continues throughout the pregnancy. Checkpoint. Although I did not discuss this in any of my previous slides, this is within your textbook and something you should know. What gestational age can an ultrasound assess gender? The answer here is C, 16 weeks. And just a heads up, a transvaginal ultrasound may be performed in the first trimester to confirm the pregnancy, but that cannot determine the gender. Only an ultrasound around 16 weeks can. Please do not get confused when you hear EDD or EDC. In your subcomps, it says to know EDC, which is estimated date of confinement. You will also hear EDD, I am sure. This is a synonym for EDC, which is also known as estimated due date. Establishing an accurate due date is one of the most important assessments for a pregnant woman. This EDD represents the anticipated birth date of their child. This provides guidance for the timing of specific maternal and fetal testing throughout pregnancy, gauges fetal growth parameters, and provides well-established timelines for specific interventions in the management of prenatal complications. You should know that most women begin labor within 10 days of their EDC. Again, most women begin labor within 10 days of their EDC. Also know that the estimated due date, or estimated date of confinement, you can say, is based on a 40-week gestational age. Checkpoint. What is the most reliable measurement of the fetus between 7 and 14 weeks gestation if a patient is unsure of their last menstrual period? The answer is crown rump length. This technique involves measurement of the fetal length from the tip of the cephalic pole to the tip of the caudal pole, so head to tail. The fetus should be at rest in assuming its natural curvature. I'm not going to read this slide, but I just wanted you to be familiar with some terms you might hear while you're in the OB setting. Gravidipara is used in obstetrics to summarize a person's pregnancy history quickly and clearly. It helps healthcare providers assess maternal and fetal risk, guide care, and communicate accurately across the healthcare team. It is the most common method. Gravida means current total pregnancies, and please note, each pregnancy counts as one. So if somebody has twins, that means that is one gravida. Para is the number of births, including live and stillbirths, that reached a viable gestational age greater or equal to 20 weeks. Abortions include spontaneous, therapeutic, and miscarriages that occur less than 20 weeks. And then we also keep in mind the count of current living children. GTPAL is a method used in obstetrics to give a more detailed breakdown of a person's pregnancy history than the Gravidipara method alone. I'm sure each of you at your clinical facilities will see the Gravidipara method within your patient's histories. However, you still need to know how to do this GTPAL method. So what does each letter stand for? G means gravida. This is the total number of pregnancies, including the current pregnancy. T means term. This is the number of births greater than as well as equal to 37 weeks. This includes stillbirths. P means preterm. So this is the number of births between 20 weeks and 36 weeks and 6 days gestation. Let's pause here for a moment. What is this fraction? So basically, pregnancy is counted in weeks and days, not decimals. Each week has 7 days. So 36 and 6/7 means 36 full weeks plus 6 days. Hence, 36 weeks and 6 days pregnant. Let's continue on. A means abortions. This is the number of pregnancies ending before 20 weeks. Remember, 20 weeks is the viable gestational age. And L means living. This is the number of children currently living. Please note, G, T, P, and A include multiple births from one pregnancy. For example, the birth of triplets count as one gravida. Another example, the birth of triplets at 32 weeks would count as one preterm delivery. So it would be a gravida 1, para 1. Lastly, L counts for each currently living child, so they all get their own number in the count. Pulse check. Please note I'm providing a less tedious scenario in this lecture. However, you will receive more scenarios in your upcoming active learning session. Please determine the obstetrical history of the following patient in this scenario. A pregnant patient, so the patient is currently pregnant, had 3 spontaneous abortions in the first trimester. Remember, the first trimester is from conception to 13 weeks. The patient has had 1 newborn who was born at 40 weeks gestation and 1 newborn who was born at 30 weeks gestation. The answer to this scenario here is B. Why? The patient has had 6 total pregnancies. That's your gravida. And remember, that includes the current pregnancy, even though the baby has not been born yet. The patient has had one term delivery. Here you see it's at 40 weeks gestation. Remember, term is 37 weeks and beyond. The patient has had one preterm delivery. In this scenario, it's 30 weeks gestation. Remember, preterm deliveries range from 20 weeks to 36 weeks and 6 days gestation. Next, you have 3 abortions. In this scenario, the patient had 3 spontaneous abortions in the first trimester. And then lastly, we have 2 living children. You should be familiar with Nagel's rule. This is not always the best way to calculate the estimated delivery date for all women. However, it is a good tool to estimate. You do need to keep in mind that the due date does give or take 2 weeks. Most women deliver within 10 days of their due date, but just keep in mind this is just an estimate. So to do this rule, you're going to take the first day of the last normal menstrual period. So for example, October 14th, 2020. You're going to subtract 3 from the number of months. So October minus 3 brings you to July 14th, 2020. You're then going to add 7 to the number of days. So that takes you from the 14th to the 21st. And then you're going to adjust the year by adding 1 year. Pregnancy is broken up into trimesters, each being 13 weeks in duration. During the first trimester, so conception to week 13, the fetus grows from the size of a poppy seed to as big as a roll of film. Emotionally, during the first trimester, the focus of the mother is on the following. First, herself, not solely on the fetus. She also accepts the pregnancy by herself and others. The mother also accepts the idea of pregnancy and identifies what must be given up to assume this new role. This slide identifies the common discomforts during the first trimester. Of course, there may be more than what's shown. It's important as a nurse to understand these and how to intervene on these. For example, if a patient is experiencing nausea and vomiting, they should try eating every few hours. Also, know that different solutions work for different patients, so sometimes there may need to be some experimenting. Another educational point for new mothers is sometimes they mistaken urinary frequency for a symptom of a UTI. Absolutely, they should still get worked up, of course, meaning get lab work done to make sure they actually don't have a UTI. But please know that urinary frequency is a common discomfort in the first trimester, as it is caused by the hormones from the pregnancy. During the second trimester, so week 14 to 27, the mother develops attachment of great value to her fetus. Family needs to relate to the fetus as a member, and the mother feels the sensation of fetal movement, also known as quickening. The mother also acknowledges the fetus as a separate entity within her, and the mother identifies with the fetus and learns how to delay her own desires. In regard to varicose veins in the legs, as mentioned on the slide, education is important to patients who sit a lot, such as those who have a desk job. These mothers need to try to get up and move around every hour or so to help circulation. I would also encourage them to elevate their legs as much as they can. During the third trimester, so week 28 to the end of the pregnancy, the mother has concern for herself and her fetus as a unit. There's also unconditional acceptance without rejection, and the mother longs to hold the newborn and becomes tired of being pregnant. Mother also questions the ability to become a good mother to the newborn. Now listen to these examples I'm about to say carefully, as they are great education points to those mothers experiencing such discomforts during the third trimester. It's important to educate new mothers how they should avoid lying in the supine position. Once they are in the supine position, gravity allows the uterus to rest posteriorly, onto the spine. The weight of the uterus compresses the inferior vena cava. This results in impeded blood flow and could result in maternal hypotension. So please educate mothers not to lay flat on their back. In regard to heartburn and indigestion, you can always educate your patients to simply remain upright for an hour or two after eating. Why? The stomach is displaced upward and compressed by that large uterus, especially during this third trimester, and this limits the stomach's capacity to empty quickly. Checkpoint. During the third trimester, what is the thin liquid that comes from the mother's nipples? How would you educate her on this? So this is called colostrum. It's a creamy yellowish breast fluid, and it can typically be expressed or leak from the breast during the third trimester. Not all the time though. This provides great nourishment to the newborn during the first few days of life before that transitions into breast milk. It's more of a whiter color, not the colostrum that's a yellow color. I would not recommend patients to express this on their own because this can actually induce labor. It's not recommended if the newborn is not ready to be born yet, as this could result in difficulties with the birthing process and cause complications. However, what you can do is to educate the mother to wear breast pads in their bra and change them frequently to prevent buildup, infection, or even excoriation.